Hello and welcome to the next episode of Outcomes for Me Perspectives. These are 15-minute conversations with experts, advocates, and patients on topics impacting the breast cancer community. Today, I am joined by Dr. Brea Shrum. She is a board-certified OBGYN in Boise, Idaho. Welcome, Brea.
Thank you very much.
I was hoping you could start us out just by introducing yourselves, giving us some background on what guided you toward medicine in the first place, and in particular, women's health.
As you said, my name is Brea Shrum. I'm an OBGYN in Boise. I've been in practice here for 13 years now. Initially, when I wanted to go into medicine for as long as I could remember since I was small. And initially when I wanted to go into it, I went into medicine thinking I would do pediatrics. And then I didn't really end up enjoying pediatrics when I did my rotation. But I was very drawn to OBGYN and women's health for a couple of reasons. First of all, at the time I was in med school and doing my rotations, my mom was going through menopause, and that was very interesting experience and difficult for her. But also because I realized as I did my OBGYN rotation and then other rotations that I really liked being able to take care of women in some continuity throughout their life and be involved in like really important milestones in their development, both as a teenager and then later on having children, and then even into menopause and that transition. So that was really kind of being able to care for women through many stages and through those very cool transitions was ultimately what brought me to it.
I've never really thought through the practice of an OBGYN quite in that way, as a full lifetime of care. And
Right.
You're not old enough yet, but you absolutely could. You could, at some point in your practice, have helped in the birth of a baby girl that you then go on to provide care for her.
I have a number of patients I've been seeing since that first started with me when they came here that were teens, you know, that we were talking about either birth control or problems with their periods or something like that, that now are starting to have children, and I've taken care of them through their pregnancies and stuff like that. And then same, I have some women who I've cared for early in my career when they were pregnant that now are going through these different phases and transitions of menopause or, you know, other hysterectomy, you know, and the need for that for some reason and all those kinds of things. And it's cool to be able to take care of those people through all those stages of their life and know their history and all that kind of thing.
Right. Very, very special and intimate relationship.
Yeah.
That's awesome. Well, I know that I am very thankful for my relationship with my own OBGYN. So thank you for what you do. I will just interject that in here now. So thinking specifically about breast cancer, because that's part of what I wanted to speak with you about today. It is said that an OBGYN should act as the first line of defense in a woman's breast health. In terms of education and just guidance on screening. Do you agree with that for women?
Yeah, absolutely. I mean, I think in general, it's the role of whoever is their usually primary care provider. For a lot of women, that ends up being like their OBGYN because of the phase of life, you know, that they're in. And even in the setting of patients that I have that have a primary care provider, I end up being the one who's doing their gynecologic care. And most often that transitions into breast health and conversations and exams surrounding that. Absolutely.
Okay. So this is something that has been confusing to me, especially over the last couple of years. And different recommendations from doctors or just things that I have read online, but
Mhm.
screening recommendations for women are all over the place. So you
Yeah.
see, you should definitely start at 40, or no, you're okay, you don't need to start at 50. Or if you
Yeah.
have any sort of history in your immediate family, you should start 10 years after that event happened with that person. You should
Mhm.
make sure you're screened every year. Oh no, it's okay now to only get screened every other year. So
Yeah. Yeah.
understandably, it's a real gray zone for women.
Yeah. Yes. Yep.
Could you give us your thoughts, your opinion on that to hopefully get a
Yeah,
little
yeah,
clarity?
absolutely. I mean, it is screening recommendations are all over the place. And to some degree, it depends on so many different factors. It depends on what organization that you're looking at. The American Cancer Society recommendations are much different than United Preventative Services Task Force recommendations, right? And it's very different depending on the woman. What are their risk factors? Are they an quote unquote average risk woman, or are they high risk? Because that's going to affect screening recommendations. Most of the time when you look at general screening recommendations, you're looking at an average risk woman, right? So, and in general, when you start screening just depends a lot on, I think, the individual's risk, and looking at that balance of screening and the risks of screening, because with any screening test, it's not perfect, right? The idea is that you're going to detect some things that may or may not be important. Those false positives can increase other downstream effects, but you also want to make sure that you're screening people to not miss something. That's the whole purpose in the first place. And so when I talk to women about screening, it very much is about an individual conversation, looking at their individual risk factors. How old are they? What's their reproductive history? Have they been pregnant? Do they have kids? At what age did that happen? Do they have any, family history of breast cancer? Variety, have they had a breast biopsy before? Like there's so many different factors that go into it, that it should be very individualized. And so it's also a discussion, I think, of the person and their concern regarding their risk for breast cancer, because there are some women who are more concerned about it than others, just because of their either personal experience or friends that have had breast cancer or family members or whatever. So I think you just have to take all of that information and individualize it to some degree. There's not any doubt, based on almost all screening recommendations, that at age 50, women should be having mammograms, right? It's that for most people, it's between 40 and 49 years old. That's kind of the question mark. And then also frequency of screening. Some organizations are recommending you should screen annually starting at 50. Others are you should screen every other year starting at 40. It is all over the board, but I think it really does have to be an individualized thing. There's a couple of different risk model calculators that we use in the office sometimes, kind of help identify that for people. Women have access to those online, Gale risk calculator and the IBIS risk calculator. And while those aren't perfect, they can help a little bit, guiding people as far as when they should be screened.
That's really helpful. It's nice to know about those calculators. And then if women don't even run them themselves, just to know that they exist,
Right.
to ask their OBGYN if
Right.
they can run them together,
Yep.
maybe
Yep.
would be really helpful.
Yep.
But I really appreciate that. It sounds like you take the time with each individual patient to make your recommendations customized to their
Right.
particular risk factors.
Well, and that's what all the evidence says that we should do, that it should be a very shared decision-making, sort of model, especially for these edges of where the obvious screening is, right? Where the obvious recommendations are on the edges of those things, you have to look at and individualize for for the person based on all those different factors. I generally, in my practice, recommend most women get a baseline mammogram at the age of 40. And then after that, screen every 1 to 2 years, certainly in their early 40s. There is a lot of good evidence to say even in average risk women starting at age 45 with, regular screening is indicated. There's been some studies recently that have said that 45 is really where we're starting to see an increase. And that 45 to 55 is very critical for most women. So I really generally try to encourage annual screening during that time frame. But again, this is where all of this ambiguity comes in as far as screening recommendations. Women with denser breasts, you have to, make different recommendations. And there is actually some evidence to say if your breasts are denser, you should absolutely be screened every year, versus in women with fattier breasts, that because the detection rate is so much higher, it's probably okay for those women to be screened every other year. So this is where that individualization comes into play a lot, because there's so many different factors.
I'm glad you brought up the breast density piece. So I have, as I understand it, if you are found, say on your baseline mammogram, to have dense breasts, then sometimes additional or alternative imaging modalities are indicated. So
there's not really a dense breast tissue in and of itself does not have a recommendation to necessarily screen. And this is in average risk women, right? To do additional screening modalities. Most of that is related to the fact that there hasn't been any evidence or data that it makes a difference, right? Because when you look at outcomes and how all these recommendations are made, they're all made based on risk of mortality from breast cancer. That's what we're looking at, right? And so when you look at that as a primary outcome in a study, you look at, okay, if we change this, is it going to change the primary outcome for this group of people? And there just isn't any recommendation for that. It hasn't been shown that MRI or ultrasound or any of those things increase not that they don't increase detection of breast cancer, but they just don't decrease mortality, right? And I think that's sometimes a difficult concept for people to grasp, that we're just talking about, is this going to kill me or not? Like that seems like, but you have to look at an outcome, at a primary outcome, and all the other things are more difficult to assess than mortality. Mortality is the ultimate sort of assessment when you talk about diagnosis, and that's for a variety of different reasons, mostly ease of measurement.
Okay. But if so that's really looking at the average risk population. But
right.
if you had felt something, or a woman had felt something, and,
right.
Yeah.
Right. That's not average risk, right? Then you're talking about a diagnostic. We're not talking about screening of the breast at that point. We're talking about a diagnostic assessment, right? So if there's something abnormal on your mammogram, or if you feel a lump or a mass or something like that, then that's a whole different, that's not screening, right? That's all of a sudden we go into this realm of diagnosis or diagnostic imaging, and that totally changes where the recommendations go. So the screening recommendations are all over the board. The recommendations, once we get into a modality of looking at a problem and diagnosing a problem or assessing that, that's a totally different situation or scenario.
Okay. A little more clear cut on which imaging would be helpful, and an easier path to get that approved.
Yes. Yep. Absolutely. Yeah.
Okay. Thank you. That is really helpful.
Yeah.
So, unfortunately, I know you know this stat, but at least in the United States, 1 in 8 women is expected to be diagnosed with breast cancer over their lifetime.
Yep.
And I guess encouraging news is that there are more and more women alive today that are survivors of breast cancer.
Yep.
Which is really amazing. But it doesn't come, this population of women don't come without side effects. And sometimes Get lifelong side effects. So
Yeah.
I'd imagine with these numbers that we're talking about, that you probably have a substantial amount of women in your practice
Mhm.
who are survivors. So
Yeah.
I'd love to hear what an OBGYN's role is in breast cancer survivorship. So maybe women who are dealing with a menopause earlier than expected, or
Yeah.
women who were in a natural menopause but are taking endocrine therapies that make that even a little bit more brutal.
Yeah.
And we know that adherence to a chemical menopause or to endocrine therapy drugs is so important that
Mhm.
women stay on for the duration that their oncologist prescribes to them.
Right. Right.
Uh, how can a relationship with an OBGYN help, to support their journey and maybe alleviate some side effects?
Yeah, I mean, I think that ends up being my main role for a lot of these women, especially, early on. It is encouraging them to continue their recommended course of treatment or adjuvant therapy, whatever that is, and helping them figure out what are some ways that they can manage some of those symptoms and side effects. And I mean, part of my job on a day-to-day basis is managing symptoms of perimenopause and menopause. The difference, obviously, with breast cancer survivors is our arsenal of things is less, and sometimes a little bit less effective. I mean, obviously, most women with breast cancer don't have the option, or with a history of breast cancer survivors don't have the option of hormone therapy as a management tool, right? So we have to look at what are those alternative management strategies. Is it something that we can just manage? Are they having hot flushes? Is their main symptom, vaginal dryness and libido more so than hot flushes, and sort of figuring out what's the right strategy in that woman, depending on what her symptoms are, to manage those things. But there are lots of options of things for women who are struggling with some of those symptoms and side effects related to either menopause or their treatment or therapy. For another kind of subset of that, to some degree, is also making sure that we're screening for the things that their treatment has put them at increased risk for, making sure they're up to date on their bone density screening, because that's another kind of side effect of earlier menopause and some of these adjuvant therapies, is that it decreases bone density. So it's like we have these women that are survivors and they're living longer. We don't want to cause more problems down the road or have other issues. So it's just being mindful of maintaining some of those, making sure we're up to date on those screenings and looking for those things. And then in general, obviously, specific things when it comes to screening is looking at, for women who are on tamoxifen, let's say, right? And tamoxifen in general is going to reduce risk of a breast cancer recurrence in a large population, or even for chemoprophylaxis in some women who haven't had breast cancer or are high risk. But it can cause certain issues or problems with the uterus. It increases the risk of endometrial polyps and precancer of the uterus. So making sure that women are aware of that, what the signs and symptoms of that are, and then also making sure that we're evaluating those things if there is a problem, and doing that appropriately.
Okay. Yes. So lots of things that you can help with screenings for, and
Absolutely.
to
Yeah.
help with from a symptoms management
Correct.
standpoint.
Yeah. Yeah. I think that's where we end up coming in the most, because a lot of the oncologists either aren't comfortable or as educated in us in all the alternative therapies, or once it comes to a point where they've transitioned away from seeing their oncologist for regular follow-up, and they're seeing us regularly, then we can help manage those things and make sure we're on top of all those screening recommendations.
Okay. Okay. I think that's really helpful for survivors to hear. It
Yeah,
takes a village, and it is really, I think,
absolutely.
important to remember that an OBGYN during this transition into survivorship can and should be a really integral part of your medical team.
Yeah, well, like I said, I mean, this is the whole purpose of this field, kind of wrapping it back around to the beginning, right? Like
Right.
our goal is to stay with women through these different portions and parts of their lives. And that includes coming back around to following up after breast cancer and continuing to care for women through that next stage or transition of things, right? And we have lots of things in our arsenal to do that, and are there to be a support.
That's wonderful. Dr. Shrum, thank you so much for your time.
Thank
This was
you.
a really wonderful conversation, and I know one that I will touch and help a lot of people.
My
So
pleasure.
appreciate you.
Yeah, thank you.
Thank you. Bye-bye.